Okay. Welcome, everyone, in the Founds Women webinar series. Thank you for joining us this morning. This is our last webinar before the summer break. We are coming back after the summer with more webinars. If you have any ideas of topics that you would like for us to be covered, or you have a good practice that we can showcase, please get in touch with us. Before we start today's webinar, just want to say that we have just launched a call for good practices, a collection of good practices, examples of good practices in preventing and ending women's homelessness. I have included the link in the chat, and I can also send it to you by email after the webinar. So we invite you to share any initiative, approaches, or research that you are involved in that supports women experiencing homelessness. This could be research, projects, or training initiatives, or specific ways in working with women, good partnership that strengthens your work and can inspire others in the field. So our goal is to gather and showcase practices that can inform and motivate and strengthen the work of our members. So in the link, you can find a link to the short survey, and please include your contact details so that we can follow up with you. We would be very grateful to hear from you. Thank you in advance. So today, our focus is on pregnancy, and we brought to you an exceptional service that promotes housing and support for women and women experiencing homelessness and their babies. It's an important issue that is often overlooked, while we know that housing insecurity impacts women's ability to engage fully with their pregnancy. It affects their access to health care, to make informed decisions, and the fears of being moved from one temporary accommodation to the other, being in unsafe temporary accommodation, the lack of privacy and the fear of child removal all impacts the perinatal health of the women. So in this context, our two speakers today, Marian Barnard and Caroline Snowe, from Dublin, Ireland, will present the work of Anew, the only dedicated support service in Ireland that provides a safe, stable environment with the tailored support for pregnant women and new mothers. Marian and Caroline will share their experience and expertise, and after their presentation, you can ask questions, and we can have a discussion on how we can all help to improve support for pregnant women experiencing homelessness. You can type your questions in the Q&A box or in the chat. And now I just give the floor to Marian and Caroline.
Great, thanks, Dalma. Good morning, everybody. Yes, my name is Marian Barnard. I am the CEO of Anew Support Services, and I'm joined by Caroline Snowe, who's one of our social care workers, and she is also a qualified midwife, so obviously a very relevant expertise for our service. So I'm going to share the screen, and myself and Caroline are going to go through, I suppose, what our service is and how we support pregnant women and new mothers experiencing homelessness. And Caroline is going to go into depth with some, specific interventions for you as professionals as well, to help this vulnerable cohort. So I'm going to share my screen. Hopefully this all works okay. There you go. Okay, so the presentation today, we are going to look at a little brief agenda for you. We're going to look at, Caroline's going to start us off with some discussion about pregnancy in disadvantaged situations. I suppose looking at some research there about the stark reality of that. Then I'm going to tell you a little bit about Anew as an organisation, what social issue Anew is addressing, and talk a little bit then about Anew's theory of change, which is a piece of work that we've done recently to articulate the work and the impact that we're doing over the last number of years. Caroline then is going to take over and speak a little bit about infant mental health, perinatal, maternal mental health, and those practical interventions that I think will be really useful for you as professionals in this area. So Caroline, over to you.
Thanks, Marian. Thanks, Alma, for having me here today, and thanks for everybody for coming on. It's a really, really important topic, and one that I know and Anew we are very, very passionate about. Unfortunately, I have to start with the kind of stark reality of pregnancy and homelessness. I suppose pregnancy is a normal life event, and I know I was training to be a midwife, that was said to us every day for the 4-year degree. It's a normal life event. However, if you're homeless, that's an abnormal event, I suppose, in your life, and you're trying to amalgamate them two together. And I suppose at Anew we try to provide some normality around your pregnancy, but we're obviously doing all that work then behind the scene to try and get the woman back into kind of a normal way of living, while trying to enjoy her pregnancy during all of this. So it's a huge a time of transition. If anybody here is a mother or is becoming a mother, it's a huge time of transition. Loads of emotions. But what we know with reports that are done, so there's a major kind of, if anybody wants to have a look on after, Embrace reports are done between the UK and Ireland, and they show kind of any adverse events or kind of I suppose situations that are kind of becoming more and more prevalent in pregnant women that are coming up. And in 2020 to 2022, what they showed was that women of multiple disadvantages were more likely to actually die in their pregnancy. And we know this because they can fall through the cracks. You see here that we have some of the research that was done that women get fragmented care and they can fall through the cracks. And we see that, that adverse events that can occur. Early detection is really, really important. Early treatment is really, really important. But the women's needs and their mental health needs change throughout pregnancy. They can come in with before they're obviously pregnant, they can have mental health difficulties, but it can be exacerbated further in pregnancy because of hormones, because of their living situation. Delivery, they can have traumas in their delivery, and then obviously in the first year of life, this huge transition into motherhood can be huge. Can we go to the next slide, Marian? Is that okay, or can I do that?
Yeah, that's okay. Yeah.
I can, yeah. Oh, thanks, brilliant. So with this report, the Embrace report, they had 275 women die during their pregnancy. That's, like, for me, I'm sure anybody else is looking at this. It's so shocking. 275 women dying during their pregnancy or the first year of life, and this is in the UK and Ireland alone. Obviously, they are considered tragedies. The most common causes of death in the women who died between 6 weeks and a year after giving birth were related to mental health, suicide, drug and alcohol use. And then more than 1/3 of these women, they were related to mental health issues. Suicide continues to be the leading cause of death in women between 6 weeks and 1 year. Suicide in mothers, in new mothers. That is huge. We cannot underestimate the mental health of these women and how much support that they do need in the first year of life. And we say it in Anew all the time, the babies get everything, especially in our service. The babies they get everything, they want for nothing. But the moms, it's so important that the moms are getting that emotional support and that mental health support that they need. Can we go to the next one, Marian?
Yeah.
Thanks. So what women are affected most? So what we see is what the research has shown is that Black women are 3 times more likely to die during pregnancy, up to 6 weeks after, compared with a white woman. Asian women are almost twice as likely to die compared to their white counterparts. We've seen it in our service. I've seen it actually just recently where a woman is from the Congo. She speaks French, and she's getting kind of an interpreter service every now and then in the hospital. That's not good enough. That's not okay. You're going in to be given medical care and support during your pregnancy. That she needs to have that interpreter there. She needs to be able to advocate. She needs to be able to advocate for herself and her baby and for safe medical care. So I suppose the links that Anew forged with the hospitals, I'll touch on it later. That's really, really important that woman was able to tell me that, and because of cross-agency links that we have, we were able to ensure that she is getting that at every single visit. Women most likely to die is twice likely to die are from deprived areas. So you can kind of see it's multiple kind of women. If a woman is Black, she's living in a deprived area, she's more likely to die. She's more likely to die in her pregnancy. That's, for me, it's shocking. And then again, and we see that, and I know any people working in the service will say domestic violence. Domestic violence is more prevalent than gestational diabetes in pregnancy. So women are more likely to be a victim of domestic violence than they are to have gestational diabetes. And we have clinics for gestational diabetes in every hospital. Yet not every woman has been able to kind of disclose to a healthcare worker that, she is a victim of domestic violence. Yet it's most prevalent in pregnancy. So that's another disadvantage for a woman, and another way that she can fall through the cracks. So 9% of women who died were classed as facing severe and multiple disadvantages. So as I've just said, domestic violence, living in a deprived area, language barriers, this is what we're seeing on the ground, is that women are then more likely to kind of suffer adverse events or die during their pregnancy or after have their baby. Mental health diagnosis is obviously is another one, and a lot of things can be put down to, she's just had a baby, or she's a little bit low. You need to know the signs. And it's not just depression, and it's not just anxiety. It can be rage. It can be disassociation from the baby, and I'll touch on that later. And I know that's a lot of information for us to just start with, and I know it's very stark information. But I think, I'm not sure if it's all women on this on today, but we fall through the cracks in many ways when it comes to health, and this is also an area that pregnant women will fall through the cracks, unfortunately. So that's a little bit just around the research. So if you can maybe go off later on in the day and have a look at the Embrace reports, they're really, really good, and they give factual breakdowns then of how support can be given as well. Can we go to the next slide, Marian? I think
That's me, yeah.
yourself.
Thanks. Yeah.
No bother.
So look, we thought we'd start off with that because I think the importance of, having specific services for pregnant women and new mothers experiencing homelessness can't be overemphasized, and that study is a stark reality. Those studies are really useful because they do give us, I suppose, some help, because what we've known has been a problem for a long time. They give us a basis to, I suppose, get funding and get our services up and running in the right way. So anyway, to backtrack a little bit about Anew Support Services, our organisation. As Dalma said, we're the only charity in Ireland that specifically supports pregnant women and new mothers experiencing homelessness. And we've been doing it for a long time, since 1981. And there have been, I've been in the organisation for 10 years, and there have certainly been times when I had to, you know, explain to people the importance of this service. And, you know, it just really hasn't been recognised. I've, you know, sat at tables of with government stakeholders, and they've suddenly said, we've never thought of pregnant women experiencing homelessness. So as Caroline said, they really have been falling through the cracks. It is being recognised a bit more, thankfully. We have 15 staff, so we're a small organisation based in Dublin, and we provide emotional and practical support to approximately 200 women and their babies annually. So really, I suppose we have 100 referrals, and then about another 100 who we would kind of class as queries, where we are, you know, we can still spend quite a bit of time with them, but we end up signposting them on to other services because, like, we are only small. We do have accommodation. We have two types of accommodation. We have our emergency and transition accommodation, and we can, I'll talk about them a bit more in a minute. We can support 20 women and their babies annually in that accommodation. We also have day and outreach services. Again, I'm going to speak about that a bit more, but those are very important, I suppose, for the women that we can't accommodate. We use evidence-based interventions and tools to measure what we do. We use the Outcome Star New Mum tool, the Circle of Limited Security, which is a parenting course, I suppose, for new mothers. And all of our interventions are trauma informed. We also develop bespoke programs, for example, for young mothers, for care leavers, women with children in care. You know, that we try to be agile in our service and recognize where the needs are different, and we build these bespoke programs around the needs of these women. So the support we give when the women, particularly when they come into our accommodation service, is very individualized, but you can categorize certain programs, you know, depending on these elements. So some of the women might be young mothers and care leavers, and we can let the programs overlap. The women that we work with, many of them are. Sorry. Did somebody say something? No. The women we work with are young, between 18 and 25 years of age, many of them. They are from marginalised backgrounds, such as migrants, members of the travelling community, and many have been in state care. So, you know, many of them are coming from those backgrounds that the women in the Embrace study came from. They're often isolated. Some of them have no support systems in place whatsoever. The only support they might have would be a team of professionals. They don't have any family support, and particularly for the young moms, the peer support is very important. They often come from chaotic backgrounds with significant trauma. So the mere fact of being homeless is, of course, a trauma in itself. As Caroline said, most of the women have experienced domestic abuse, which is also huge trauma, and many, many other difficult situations, and then homelessness and pregnancy as well. They're at a high risk of exclusion, poverty and homelessness anyway, and the pregnancy increases this risk, and that's just a well-known evidence-based fact. So our services roughly fall into 4 categories. The first one is our supported temporary accommodation, which is Cherry Blossom Cottage, and it's a cottage with 4 ensuite bedrooms where women can come when they're pregnant and get the support and care pre-birth, and they have their baby and they come back and they can, you know, we take care of them, we nurture them, we help them with the baby. They do we do key working with them. Each woman has their own key worker. And we really help them into new motherhood and to develop that bond with their baby. And also, as Caroline said, to be able to spend a bit of time, caring for the woman herself. And that's really a nurture piece. After that, then the women have to move on, and we have a housing officer. So all of our referrals come in through our housing officer. It's a very busy role because every single woman comes via the housing officer, but she's always working with the women to help them secure long-term accommodation. So that will be happening as well while they're in Cherry Blossom Cottage. Then last year we secured a second house after many years of trying, called Lily Lodge, and that's transitional and step-down accommodation. So now we're able to move the women in there once they've come through Cherry Blossom Cottage, and that gives us a little bit of extra time to find them their long-term accommodation. We were finding that that was becoming more and more difficult, and many of the women coming out of Cherry Blossom Cottage were ending up in family hubs which weren't suitable for a new mom and her baby. So having this step down accommodation has been, it's just been life-changing, really. And this is more independent living. It's own door. So we have 6 units, and each unit has its own kitchen and washing facilities, and the women can really start to blossom in there with their motherhood journey, and also learning budgeting and paying bills. Many of them won't have had to do that at all until this stage of their lives. We still have support in the transitional accommodation. We have 2 family support workers who help with around health and safety and life skills. And that is still really needed there, because it's the same women that we've been providing the support to in Cherry Blossom. And we have done the nurture piece, and this is more about empowering them by the time they move in here. And all the while our housing officer is working to look for the long-term accommodation for them. And already, we've only had that house up and running less than a year, and already we've had 6 move-ins and 3 move-ons. So we have a good movement through the house. We also then have those day services in Haven House in Dublin, and that's a very busy place. We provide the housing support in there. The housing officer will do housing assessments in there and meet the women for the first time, and base herself there sometimes as well. There's some education programs that we run. Many of them we run ourselves around life skills, and Caroline does the antenatal and sexual health. And we also run a course, a FETAC accredited course called New Beginnings, which gets women back into education. And, it really gives them a bit of confidence then to move on with their education or maybe into employment. We have our coffee mornings and things there that's around peer support. And it's also a place where we keep our donations, so the women can come in and get baby supplies. They can get hygiene supplies for themselves. We at Christmas we're very lucky. We get some great donations from corporates and donations from various grants, and we're able to give vouchers for shopping and that type of thing. So that's a way of getting the women in. We also provide outreach services when we can. That is dependent on funding. Unfortunately, it's not something that we have. We have very steady funding for the accommodation and the housing piece from Dublin Regional Homeless Executive and from TUSLA. Our outreach tends to be grant driven, and we sometimes get grants to provide that extra outreach services to other emergency accommodation, to maternity hospitals, to international protection accommodation services. And we feel this is a very valuable part of our service, and we would, we're working hard to get sustainable funding to keep that going, because, some of the women do need really a lot of extra support going to appointments and maybe to professional meetings where there's maybe a child protection meeting where they do really need that extra support. And really, we focus, as I said, very much on the housing throughout all of the services. But as Caroline said, the women are pregnant, they're new mothers, they really need support. And you need to really we keep emphasizing that all the time in all of the services that we do. So you've heard me talk about nurture and empower as I've been going through, and that really weaves through everything we do. And that's a I suppose it was always there in the background of things that we were working on. But Caroline, when she started, I don't know, about 3 years ago, she herself and another staff member really put it together as a program of work for us. And that was able to happen because we did get some funding, got some funding from the Catherine Howard Foundation, and we were able to really develop that up as something that we focus in on. So it's specifically for pregnant women who are homeless. We really recognise that maternity services don't meet their needs. They assume the woman has a home and a partner, etc. And the women are often too embarrassed to admit that they are homeless. Also, there's that real fear of their baby being taken off them if they admit that they're homeless. We check they're okay around antenatal. We get their information, gain their trust, and signpost where necessary. And then if they can come in and get the one-to-one pregnancy support. So, you know, gaining the trust and them telling us their story, that they don't have to keep repeating it all the time, is a big part of what we do. And we can be there to advocate for them and help them and empower them. Education that Caroline does, and Caroline will talk a bit more about preparing for birth, packing the hospital bag, and we make sure every woman has a hospital bag. We get grants and donations that we can do that. Signs and symptoms of labours, changes to the woman's body, and we make sure that as everything is tailored to the woman's current needs. Women can ask questions and they have a private, safe space to talk about things that are going on that they might find embarrassing to talk about if they just, you know, go straight into the hospital. Really importantly, we teach them the language to advocate for themselves and to be able to ask questions, and you know, that's all really part of the empowerment. A picture there of food there. We provide a wraparound support, and you know, it's very much around as well the making sure that they are eating properly. You know, often in homeless accommodations the women don't have cooking facilities, and you know, sometimes they haven't learned, I suppose, skills around, you know, planning their diet. So we really help with that. We make sure that they're eating right, that they are as healthy as possible, and that they have the hygiene facilities. So our day service Haven House is actually a house, and there's a kitchen in it, and there are bathroom facilities, and so we're able to do a little bit of work around any of those basic life skills there. The women provide support to each other through shared experience of facing homelessness during pregnancy. And then, as I said, we do those coffee mornings, and we get women to come back who have been through the service. So there a huge amount of work gets done in there. Again, some of it is a bit dependent on grant income, and it goes up and down as to how busy it is. So, you know, again, we really want to make sure that the people in authority, I suppose, are recognising the need to fund these services. So the social issue, we're doing all this work, but we have to acknowledge there's still social issues there that are kind of maybe blocking things. Firstly, I suppose a major thing for us that we've been highlighting for years is that the number of homeless pregnant women in Ireland isn't counted anywhere. They're not categorised at all in homeless figures. And we know from talking to other homeless services that it appears to be increasing, and the medical social workers have very high caseloads. And even at that, they're not always able to ascertain if a woman is homeless, because sometimes they're like part of the hidden homelessness, and they, you know, that we just don't know about it. So the numbers are likely to be even higher than we're estimating. But as I said, there's actually no figures for that. So as Caroline said, the women are at a high risk of mental health issues and postnatal depression, and this trauma transfers to the unborn baby. So I think there's very good evidence for that now. The first 1,000 days is the most important part of a person's life, and that includes the pregnancy and the 4th trimester, which is those early days during pregnancy. So, you know, even thinking about, and Caroline's going to talk about perinatal mental health. When I first heard that term, I was like, well, you know, they're only a baby. How can they have mental health? But it's true. It's a real it's a real part of our development and a really important part of our development. And we want to make sure that the new baby isn't experiencing any pain, as much as possible. These women that we work with are very difficult to engage with because they don't trust people in authority. They are transient, they're moving around a lot, and they have more health issues, including high-risk pregnancies, premature births, and low birth weight babies, obviously from the situation that they're living in. They mightn't be eating properly. They may be in an unsafe relationship where there's domestic violence, and you will get all of these poor outcomes. And we really want them to be in a safe place, like Cherry Blossom Cottage, and minded and looked after and nurtured to give them the best chance. So we did an exercise recently called the Theory of Change. We involved the women in the whole process by getting feedback from current clients and from previous clients, and we completed this Theory of Change exercise. And we really wanted to, dig into what we're doing in Anew and what the impacts are. So feedback from the women showed that the women's needs are focused on emotional support. Other homeless services don't offer the level of support that Anew do, and this is the real difference that we provide in Anew. So, yes, they do need safe accommodation, but they really, I suppose, thinking about anybody who's pregnant and had a child, you can imagine, you can remember, I have 3 kids, I can remember, all the support and help that I got just naturally through my own support systems. So these women don't have support systems in place at all, and they're just very isolated. So they really appreciate that when they come to Anew, and they really they report back that when they come to Anew, they can finally enjoy their experience of pregnancy and new motherhood. So prior to coming to Anew, there's a fear and anxiety, and they're able to enjoy it when they come into Anew. So our Theory of Change, then, we looked at what the problem is we're trying to solve. So it's pregnant women and new mothers experiencing homelessness with limited or non-existent support network, in need of pre and postnatal supports and secure accommodation. So that's really very succinct and clear what the problem is that we're trying to solve. Our solution, again, we want to provide these women with pre and postnatal supports and short-term accommodation while seeking the long-term housing. So how were we going to do that? How have we been doing it? Case management, preparation for birth, early childhood parenting skills, short-term accommodation, which is Cherry Blossom Cottage, our transitional accommodation, Lily Lodge, our housing support, practical supports, and cross-agency collaboration. The short-term outcomes that will be experienced then, improved physical health, improved mental health, increased safety, increased attachment with baby, which is hugely important, increased confidence, so the empowerment to move on, and improved self-esteem. The long-term impacts then, confident parenting skills, increased social connection, improved community supports and connection, improved employment opportunities, increased independence, recovery from trauma, and early childhood attachment is developed. So huge impacts from these early interventions. And overall, our impact statement then is the women have safe, secure accommodation and are confident mothers with a support network that meets their needs. So, that's a really, I suppose it's our elevator pitch that we've developed to very, in a page. I could talk for hours about all the things that we do and have done in the past, and probably go into too much detail. So this is a really nice way of explaining what we do in Anew. And based on this, we have done what they call logic models, which are really models of, I suppose, models of care, models of service for our three elements of our service: Cherry Blossom Cottage, Lily Lodge, and Haven House, which is the day services. So You know, we're happy to share all the learnings that we have as well on that. So now I'm going to hand over to Caroline to talk a little bit about the other elements.
So I know Marian touched on infant mental health and obviously the importance of it. And, you know, like this says here from the Parent Infant Foundation, you know, it reflects whether infants have secure, responsive relationships that are crucial for their development. And it lays the foundation for their future emotional, social, and cognitive outcomes, influencing a child's ability to thrive in later life. And you know, we all want the best for our babies when we're born and when they're born. But I suppose when I meet some of the women and I'm doing maybe one-to-one antenatal education with them, I bring up infant mental health, and I might kind of tailor it in a different way, and I won't call it infant mental health, but you know, I might say, you know, do you sing nursery rhymes to your baby when, you know, and you know, to your tummy? And they'll look at you and they're like, you know, I've had one woman recently who didn't know any nursery rhymes. So she didn't know even that simple kind of connection and singing to her baby or talking to her baby. She'd been in care all her life. So she didn't have an experience of watching a mother do that with an infant. So I inadvertently become a nursery rhyme teacher and a midwife in a one-to-one antenatal class. But it's imperative for the baby's mental health. And you're trying to constantly, I suppose, break generational trauma, or get the woman, not for us to break it, for the woman to see that there's, you know, the generational trauma that's there, the blocks that have been there, and give her the building blocks, I suppose, to break that trauma and to stop that generation from passing down, and for her to do it differently with her baby. And we see it in the cottage all the time. You know, you will see women looking at the staff and how the staff are talking to the baby, the eye contact, the baby is going and going back, and you're telling the woman, you know, this is so important for the baby's brain. So it's really simple, effective things that you can do with the women when they're in your care, you know. And it's emulating, you know, how you would like them to be with the baby, how they speak to the baby. But it does lay down the foundation for this baby's life, you know. Can we go to the next slide, Marian? So obviously key factors influencing the baby's mental health are early relationships. So like I said, that kind of how a woman is responding to the baby in early life, and looking at staff and how staff are doing that. And we do that with the Circle of Limited Security in the cottage. And we do it in Haven House when we do our coffee mornings, and other mothers they're watching each other and they're watching how they are with their baby. And it's so important, and it's so important to name that as much as you can, and to explain to them how important that is for the baby to feel safe, to feel seen, that it's so important. Obviously, we know that environmental stresses have a huge impact on the baby's mental health. I was recently at a child protection conference for a lady, and you know, they spoke about how, you know, a newborn baby is actually usually one of the first victims of domestic violence. Inadvertently, they can get assaulted during a domestic violent between the mother and the father, or between whoever the caregivers are, and it can have a huge effect, long term, mental and emotional effect on these babies, you know. And it's critical for their brain development that they're getting kind of, you know, a loving, nurturing, caring environment. And that's a huge amount of pressure on the mother, if she's, you know, trying to heal from having maybe, you know, a difficult delivery, or not having a difficult delivery, just having a delivery, and she's, you know, she's exhausted, and she's nothing to give, you know. So if you can, you know, give as much to that mother than she can give, and it does take a village. It absolutely takes a village. Anyone who's had a baby will say that, it can't be done on your own. It's so important. It's so important for this baby, for this baby's little brain and for their development, and that the mom is as healthy as she can be, mentally and emotionally and physically, in order for for the baby to thrive in their life. And we go for the next slide, Marian. So obviously, how do we support that? So we engage in nurturing interactions. Um, you do hear kind of, oh, let the baby cry, all this kind of stuff. It's like, no, you don't just let a baby cry. A baby's trying to communicate with you. And we try to kind of explain that to the women. That's the baby's way of communicating with you. I know it's not nice at 3 a.m, but that is the baby's way of communicating with you. So we're constantly trying to kind of promote a secure, healthy, emotional development between the mother and the baby. Obviously, professional supports and community supports are really, really important. Peer support is huge. Mother and baby groups. The public health nurse is really, really important to ensure that the baby is being cared for and that bonding is happening there. Early intervention is crucial. If you're picking this up during pregnancy, that the woman is not is disengaged from the pregnancy, there is steps that you can take. It is out of your scope of practice if you're not a perinatal mental health support worker. It's out of your scope. It's okay to pass this on to say, we need to kind of refer you into the hospital, and make sure antenatal classes are really, really important if you can get her to engage in them. So early intervention is really, really important in the pregnancy in order to ensure that infant mental health is being supported. It's a huge thing, and don't be afraid to link in with the hospitals. Don't be afraid of that cross-agency support. There's great support out there, and once the woman has a trusting relationship with you, quite often that she's happy to go to these services once kind of you can support her, whether that's to go with her in a practical way with her and baby, but it's really, really important that she knows that there is that cross-agency support there. We go for the next slide, Marian. So maternal perinatal mental health. So what is that? So basically it is the mental health of the woman during her pregnancy, and up until the first year of motherhood. And it's all linked into her emotional well-being during this period. Mental health difficulties can arise in the pregnancy or in the first year, or it can be because it was there before she got pregnant. I suppose red flags, that what I would call red flags to look out for, is anxiety, depression, and two that aren't spoken about a lot is anger, rage, a disassociation from the pregnancy, not wanting to kind of go to appointments, a lack of interest, really, really high highs, really, really low lows. I know, when I was doing my training and we were going out with the community midwives, a huge red flag for a new mum is if you go into a home or you go somewhere where a woman is staying and that place is absolutely immaculate and she has a newborn baby, that's a red flag. It's not normal for everything to be absolutely perfect when someone has a newborn baby, unless you have a cleaner, unless you have a cleaner daily. But it's not normal, and that would have been a really big red flag for us. Excessive cleaning is also another one that you see women, maybe they're washing their hands constantly, their hands are red raw from washing, everything is just absolutely perfect and they won't sit still. They're red flags. So what kind of can we do with that? There's a few things that we can do, but just to recognize that, unless you're trained in this, in a mental health, you're a mental health nurse, a psychologist or a doctor, it's out of your scope of practice. You can support her on a daily basis, but she does need kind of external cross-agency support. And it's to speak to her about that. Do you feel rage like that often? Do you feel it with the baby? Is it, are you sleeping? And you can kind of pick it apart with her. But obviously she will need more support than maybe you'll be able to offer to her, And we go for the next slide, Marian. Thanks. So the vulnerabilities during pregnancy, and I know I kind of talked about it at the start around domestic violence. So there's multiple vulnerabilities, I suppose, that we see working with the women that we work with, and sometimes they can have all of these. So again, I'll refer back to the research. They are more likely to die. They're more likely to die in the pregnancy or the first year of life. So domestic violence, I suppose. I don't think there's ever been a woman that I've ever worked with that has no history or is not in a relationship that there's domestic violence. Um, they unfortunately go hand in hand, I suppose, with the women that we work with. We work closely with Women's Aid. We work closely with the domestic violence services, and we work closely with the hospitals in relation to this. A mental health history, obviously, as I touched on before. Homelessness, while you have I suppose, the obvious homelessness where a woman is sleeping in a tent, she's sleeping, I've had a woman sleeping in the underground of a car park. They're sleeping in homelessness services, but the silent ones are the couch surfers. So they're the women that will come into a hospital and they'll give their address as 123 Main Street. So to a midwife, I don't know that that's a homeless service. So, or that she's actually staying on someone's couch. She's sharing a bed with two friends. That's not sustainable. That's not going to be sustainable when she gets bigger. It's not going to be sustainable when she gives birth. But the couch surfers will go under the radar a lot of the time. And they don't see themselves sometimes as homeless. Another thing would be, I suppose, pain or physiological changes can be exacerbated by their living situation. I had one woman who kept on complaining of a shoulder pain. I have shoulder pain all the time, a shoulder pain all the time. But she was sleeping on a couch. She was pregnant, so she didn't even see that was kind of an issue, Health difficulties is a huge thing for vulnerabilities for women during pregnancy. So hyperemesis gravidarum is if I don't know if everybody is aware of it. It's a lot more than morning sickness. So morning sickness is a normal physiological event that happens in the first couple of months of pregnancy. Hyperemesis gravidarum is continuous nausea and vomiting throughout the entire pregnancy. It is extremely debilitating for a woman, and quite often she can't lift her head off the pillow. But if you're sleeping in an underground of a car park or you're sleeping in a tent, how is that managed? These women are a huge risk of low birth weight babies, are a huge risk of delivering early, are a huge risk of becoming dehydrated because they're not able to even sip water. So that's another huge vulnerability for a woman. Medication that can be given for this pregnancy, you have to get kind of a consultant to sign off in Ireland for it. I think that's changed quite recently. But if you're not going to hospital appointments, you can't get that medication if you don't have a medical card, if you don't have an address. So that's another vulnerability then that kind of the woman falls again into the cracks. Gestational diabetes is another one. If you're you have to have a kind of a set diet. If you've no cooking facilities, how can you do that? So they're the little things that I suppose to think of when you're meeting pregnant women in homelessness. Our service, we have kitchen facilities. They can come in and cook whenever they want. If they're coming into the service, they're more than welcome to do that. Fear of labour. I don't know many women who don't have a fear of labour. We try to, they won't attend antenatal classes because they're tailored to kind of, I suppose, one cohort of women, and if I've heard it in the antenatal classes where they say, when you come home with your baby, you and your husband or your wife come home with your baby, that's not the case for everybody, and it can invoke a lot of embarrassment and shame. So women don't want to go to them classes. and they can miss appointments as well. And that can be as well, though, due to the transient nature of homelessness. And it can be due, they can't afford the transport. They can't afford. So we would, if we can get them, transport cards that they're able to get to their appointments. We link in heavily with the hospitals to ensure that they are attending them appointments. But they're huge vulnerabilities for these women. Another one can be hospital staff being unsympathetic to a woman's current situation. And there can be prejudices there. There can be, they have their own kind of feelings around that. Are you really homeless? Or you're staying somewhere. So that, that can also be a barrier for a woman. Language barrier is huge. Literacy issues are huge. You're giving a woman a whole load of information on paper and she can't read. How's that helpful? So no interpreter being provided, or inconsistent services of interpreters. So that's something that we would highlight kind of quite quickly when in our referrals, when we sit down with a woman in an assessment, to try and assess how much information she can take in and what way she takes it in. We tailor a lot of our antenatal education around that. We use a lot of props. I have, crocheted placentas and pelvises, and we'll use any way possible in order for the woman to get the information that she does need. Another vulnerability for a woman is unable to access support and a support network. If a woman is in a hostel in Dublin but her family is down in Cork, if you're not from Ireland, it's not really that far. Ireland is quite small, but it could be a 3 or 4 hour bus journey. So the supports then can be kind of, broken then for the woman, and they're so important. And while it's important to have professional support, family support, friend support is so important for a woman. And as I said, unable to pay for transport to and from the hospital can be a huge one. And another thing, that's just written down there is that just because a woman is pregnant doesn't mean that it's a protective factor for suicide. It actually can exacerbate the woman's mental health. So there's kind of I know it's quite a big list of vulnerabilities, but as I said, there's a few women already that I'm working with in groups on one-to-one at the moment that would fall under nearly every one of these categories. So it's to keep that in mind when you're with women that are pregnant. We go for the next slide, Marian, please. Thanks. So the challenges, I suppose, the physiological challenges, as I said, fear of birth, the unknown, the lack of control. We do a lot around kind of pain relief in labour. And we talk about alternative methods when we're doing antenatal education, around breathing, giving them as much information. I know I'm a midwife. I worked in one of the busiest maternity hospitals in Europe, so I'm able to kind of, I suppose, talk them through each step. But it's so important that they do go to the antenatal classes, because they do this in the classes, even if you as a staff member can go with them, or if it's on Zoom, that you can sit with them and kind of take notes and make sure that they are taking in that information. Shame and feeling like a failure is huge. It's huge for these women. Not having their hospital bag, not being there on their own, not having anybody with them when they're giving birth. It's a complete change to their life. And I suppose it's really, really important is, while this is a normal life event, if this woman has come from care, if she's come from, quite a turbulent background, she may have never been actually mothered. She may have never have been parented the way she would like to be. So it can be a real struggle for her to do that. And she needs the tools, and she needs, the patience, obviously the patience to be there with her. And obviously we give that in the cottage and all our services, is that, the patience for them to give them the tools for them to parent. Changes to your body is huge, especially for the younger girls. They've no idea what's happening to their body. Quite often they don't know what any of their body parts are called. So sometimes the start of my antenatal classes are about, naming the different parts of your body and what are they. If you're going to have a vaginal examination during labour, they need to know about that. So that's something that we would talk about a lot. Other challenges there for the pregnancy, obviously, is unsupportive family. partner or due to religious reasons, we're still seeing that women are being thrown out of their home because of, maybe their partner is from a different religion or they're not married. We still see that. We still see that all the time. So there are more challenges there that are there for that woman besides her whole body changing, and as I say to women all the time, from the minute that pregnancy test says positive or says pregnant, their lives change, and they change mentally, physically, and emotionally. We go for the next slide, Marian, please. So how do we respond? I suppose it's a trauma informed. We do a lot of pre-birth and post-birth planning. And that's even if a woman doesn't come to our cottage, we do a lot of pre-birth planning. We do a lot of post-birth planning. We do a lot of cross-agency planning with the medical social workers, with maybe a drug liaison midwife, with the public health nurses. We will liaise with them in order to plan ahead. So I suppose, for the want of a better word, it's prepare for war in times of peace. So before baby comes, we try and prepare as much as we can. So obviously, as the slide says, what does this pregnancy mean to them? So what do they need? And quite often they don't know. So I suppose early intervention is really important. So sitting down and doing antenatal education with these women from kind of 22, 23 weeks. So you're building up that relationship and they're kind of starting to realize what they want and what they don't want. And as I said, lived experience may impact on their birth. So who can help them? That's what's really, really important. And if it's, as I said, always be aware of your scope of practice, and there's only so much that one person can do. Yes, I'm a midwife, but I'm constantly in contact with the hospitals or with the perinatal mental health team, and because that's out of my scope. I can't help there. So what can I do to support them? So we'll just the next slide, Marian, if that's okay. We obviously utilize the supports that the woman have. If there is family support there, we do try and link in with the family. We will get to meet the family. And to be able to help with her. Sometimes there's external supports. I've obviously touched on the perinatal mental health support, housing, and we've our housing officer. We work closely with the county councils, and also child protection issues. So we do work closely with the Child and Family Agency, and they're a huge support. A lot of women will be quite reluctant to link in with you, of fear of having baby taken off her. But we have had really positive experiences with the Child Family Agency, and we work closely with them in order for the woman to keep her baby and to get the support that she needs. So yeah, we've that support is also hugely important for the woman, and that can be kind of long term as well when it comes to child protection as well. We'll go for the next slide, Marian. Thanks. So building a support network for the woman, connecting with other mothers is paramount. It's huge. They need to be able to watch other women emulate kind of how they parent. And we see it in our coffee mornings all the time, and babies are getting swapped around the whole time, obviously, as I said, perinatal specific supports, really, really important. Pre-existing mental health supports. A woman could have been linked in with other supports previous to that. Ensure they're maintained throughout the pregnancy, and that the woman is okay, that you link in with them to kind of ensure that they know what's going on with the woman. Infant mental health support and the infant relationship are huge for the baby. Obviously, as I said, mother and baby groups are really, really important. Breastfeeding groups, really, really important. And a woman can go to these breastfeeding groups during her pregnancy and forge them relationships during her pregnancy. And that can be done anywhere, and they're everywhere. But the breastfeeding support groups are everywhere, mum and baby groups, local libraries. And it's important to have that information up in your service so the woman knows that then groups are there for them. We'll go for the next slide, Marian. So coping as a parent, self-care, and we can all struggle with this, with self-care, but it's really, really important. It's a really important factor of our service is self-care for the woman. As I said at the start, the babies get everything. So self-care can look like being able to just have a shower, and someone and minding the baby for her, making sure that she's eating. It is so important that the woman is eating. She needs an extra approximately 300 calories a day during her pregnancy. Sometimes when they come to me, they come to me at, say, 11 or 12 in the day, they haven't eaten at all, so self-care is really, really important. Fun and joy is really important, because for some of our women, this is their first pregnancy. This is their first experience of pregnancy. So you want to bring a little bit of fun into it. And we do that, during our antenatal classes. We do have a lot of fun. Safety. A safety plan is obviously really, really important, that you have someone that can take the baby when it's just getting too much. And it's so, so important for that time away. Prioritizing sleep, the little bits that you can get in between. It doesn't last forever. They do eventually sleep, but it doesn't feel like it at the time. And there can be other children, and there can be other children that are in care, and you have this baby. So it's managing that and supporting the woman during that. There's a lot of guilt there, and it's just providing that space. It's meeting the woman where she's at, in her life, So, and as I said about the kind of going into an accommodation that a woman was in and everything is perfect, it's to notice if there's a kind of a drive for everything to be perfect. Because it will end in failure. It's like there is no perfect mother, there is no perfect sleeping baby, and it is, like, as I said, it's all about balance. It's all about balance. If the win today is you got to eat a meal, brilliant. That's that for us will be a win. So practical tips for yourself. So physical. Always make sure that the woman is linked in with a doctor in where she's staying at the time, and that she's linked in with a maternity hospital. Both are really, really important. Obviously for the GP, not so much during the pregnancy, but definitely after she has the baby, to ensure that the baby is getting developmental checks, is getting maybe vaccinations that the baby needs, that the weight is being checked. Has the woman access to a kitchen to prepare food for herself? So this obviously it's huge for women, and then it's further exacerbated if she has any medical conditions such as hyperemesis or gestational diabetes. So if she can prepare her food, that is so important. We will look for, if we can't provide it in the evening times, we will look for services that will link in with that service and make sure the woman has a contact name to go to that service, to make sure that she has somewhere to eat. It's so important for her. To make sure that the woman has access to medication that's necessary for her pregnancy. We would advise that all women take pregnancy vitamins during the pregnancy. They're really, really expensive. Own brand pregnancy vitamins will do. Folic acid is really important, and that's something to talk about from kind of early pregnancy, but they may not have access to this. So can you make links with a local pharmacy near your service, maybe, that can kind of maybe provide that for you, So the mental kind of, when it comes to mental tips, every hospital, I know in Ireland, I'm not sure about other services outside of Ireland, I know in the UK they do, has a perinatal mental health department, and it's specific to women during their pregnancy. Some hospitals will go up until the first year of life, and other hospitals are up to 6 months. You need to speak to the woman about that. It needs to be flagged that she's homeless. She may not have any mental health difficulties, but it's to flag to the team that there is a woman that has a vulnerability there. Because, as I said, early intervention is so, so important. So the earliest that you can do this, the better. The other one is the medical social work department. Again, you need to speak to the woman if that's okay to refer her on. Quite often at a booking visit, she won't have disclosed that she's pregnant. So it's to kind of, I suppose, help her understand that it is an additional support. The medical social work departments do invaluable work with the women. They will help around housing. They work in conjunction with our housing officer all the time around housing, around getting a buggy. There's loads of different areas that they can help. So they're really, really important. I suppose the biggest one for us is the emotional. Can your service provide one-to-one or group emotional support for the woman, where that they just sit and they just talk about their experience, their pregnancy so far, what that's been like. It's just a space for her to talk about her pregnancy and an experience so far, non-judgmental, and it's just so important for her to talk about it in a safe place, you know, away from maybe the hostel or somewhere that she is, and make the pregnancy the primary conversation. Because quite often every visit that she's going to, it's around the homelessness, it's around her housing, it could be around child protection. So it's about, how's the pregnancy going? How's it going for you so far? You know, what was your mom's pregnancy like? Let your service be the space for that woman to connect and enjoy her pregnancy. And also another thing is it can be done via WhatsApp, video call. Like I said, meet the woman where she's at physically, you know, as well. And one woman that I worked with, she worked 9 to 5, so she wasn't able to do that. She was in a homeless service. So in the evening time, we did video calls, and some of it was around antenatal education. Some of it was just talking about what her childhood was like and what it'd be like for her to be a mum. You know, so it's kind of honing in on them little things. If she's working 9 to 5, how can I kind of support her in that? I don't know. Is there another slide there, Marian? That's it. That's all the information I can give you for now. Thank you very much.
Now I know we're gone way over time. So.
No problem, no problem at all. Thank you so much, Marian and Caroline, for your presentation. It was great. So thank you so much for guiding through us the challenges, the vulnerabilities of women experiencing homelessness in pregnancy and in your new motherhood. And I think listening to you was make us clear that the women have specific support needs, and it's great to see how your services are able to provide that kind of support for women. And I particularly liked how you said that this allows women to enjoy the pregnancy and the new motherhood. I like the language that you use there, because it's often not described that way when it comes to women experiencing homelessness. So thank you so much for the presentation. I'm checking now if what are the questions. I see a question if the presentation and the slides will be able to share. Yes, absolutely. We're going to put it on our website, but I can also send it to all participants. I agree that it's a great resource, and I really think it's a great idea that participants would like to share with their team members. In fact, I think listening to you both made me think that how useful some kind of support tool would be for midwives and healthcare professionals in maternity care to understand what you described of the challenges and the specific needs and realities of women experiencing homelessness, but also equally important for those working in the homelessness sector to understand what they can do to support women who are pregnant in their services. So yes, we got the message that it was very informative and appreciated, and it's great to hear. I'm also moving to the question box. We had 3 questions. The first one is to avail of Anew services, does the mom need to be on the Dublin housing list?
Yes, she would have to be on either the Dublin City Council, South County Council, or Fingal County Council. Unfortunately, our service doesn't reach outside of Dublin at the moment, but it's needed in every county, you know.
Just if they are using our day services and they're willing to come into Dublin, we can work with them on the day service. But our accommodation services, we have to go through central placement services, and it's linked to the 4 Dublin local authorities.
Thank you. The next question is Do you know of any similar services in London or England that are open access? And maybe I can broaden this question to Europe for if anyone among the participants have similar services, please share with us in the chat box. But the question is to Marian and Caroline. Do you know a service in London or
the only service I know, I can't think off the top of my head the name of it, but I think it's working with women who come from prison and are pregnant, that are kind of coming back into kind of society. That's the only one. I'm not familiar with anyone outside of ourselves, unfortunately.
To be honest, I think the UK maybe do have some services. I don't know the name of them. I know that in other countries, there, for example, in Spain, I spoke to somebody who had set up a charity doing this work. So often it is an unmet need, and an NGO will set up to do that. And again, when you listen to Caroline speaking about I suppose all of the extra pieces around pregnancy, it is very hard for a homeless service to cover all that off. So it's a very specialized piece, and I think that's one of the things we want to highlight.
Yeah, absolutely. I think there's a service in France, but this is certainly something that we can look into and find in our membership as well. Boruka has a question that how long can mothers stay after giving birth, and where do they go from your service? I think that refers to the Lily Lodge, the transitional step-down accommodation. How long women are staying in that service?
Do you want me to take that, Caroline?
Yeah, if you want to.
So the Cherry Blossom Cottage, it's a 6-month stay. So I suppose in an ideal scenario, they come in maybe around, I suppose, 20 weeks pregnant and have their baby, and they're there for a few months post-birth. In reality, what's happening, they come in much later in their pregnancy because of lack of space in our service, and other homeless services are also finding that but it's harder and harder to find accommodation for pregnant women. So really, by the time they're getting that good, safe accommodation, they're quite far along in their pregnancy, which is not acceptable at all to be in the unsuitable accommodation. But then the move on to Lily Lodge, that's a transitionary accommodation, and the stay there is recommended to be 12 months. And it's a different type of accommodation, so we are bound by some legislation around it. So really it's exactly what it says on the tin. I suppose it's transitionary step down accommodation, and then we work really hard to move the women into their secure long-term accommodation. It's quite small. It is own door, 3 studio apartments and 3 one-bed apartments. It's a lovely, newly refurbished house, really, really nice, but it is small. And as the baby gets bigger, the woman will feel the need to move on anyway to her more long-term accommodation.
Usually the women, Dama, will link in with their service for as long as they need. After that, in the day service as well, they sometimes will contact us on their second pregnancy for a little bit of support, or a little bit of guidance on kind of where to be signposted to another service. So I suppose that's kind of a testament to the relationships that are built up with the staff and the women. There's a real trust in relationships are built up. So they do feel they can contact us kind of at any time then after.
Thank you. And Janine shared with us an important tool that she developed for care guidance or supporting pregnant women experiencing domestic violence in pregnancy. Thank you, Janine. The link to the resource is in the chat box, so you can access there. I think our webinar is coming to an end now. I will share with all of you the resources mentioned and the presentations and the recordings, which will also be available on our website, on the FAMSA website. Please do share your practice with us, because it can really inspire others. Thank you to Marian and Caroline for joining this morning and sharing the important work they are doing at Anew. Thank you, everyone, and have a good day.
Everybody.
Bye-bye.
Thank you. Thanks, everybody.